I'll go ahead and get started. Welcome to the AO Trauma North America online series. This is the 3 cases Fireside series, and today we're going to talk primarily about phalanx fractures. And my name is Tom Hunt, and I'm going to be your moderator through this session. We can thank Dr. Marco Rizzo for his leadership and his development of these sorts of programs, as he serves as the chairperson for the AO HAND North America Education Committee. So thank you, Marco, if you're on the phone on the webinar. So as mentioned, I'm going to serve as the moderator for this session until about 8:15 Eastern time tonight. We're very fortunate to have Dr. Mark Baratz as our sage. Dr. Baratz is the clinical professor and hand fellowship director at UPMC in Pittsburgh. We're also very fortunate to have Dr. Nicole Zelenski. She's assistant professor, director of hand and upper extremity surgery and the service line at Grady Memorial Hospital, and is part of the Emory University program. And finally, Gary Solomon is a therapy director of Chicago Metro Hand Therapy in Arlington Heights, Illinois. Thank you all for attending and contributing. These are our potential conflicts of interest. So AO North America is an independent nonprofit surgical society, so it does not endorse or promote any product or service. So the things you see, the implants you see, and the procedures we perform are really for demonstration purposes and for teaching purposes, as opposed to any commercial component. There is CME associated with this webinar today. The ACCME is providing that continuing education through AO North America, and with appropriate participation, this is worth 11.25 Category 1 units. Your CMA units will be available 24 hours after the conclusion of the series. At that point, you'll have an evaluation questionnaire, and once you complete that, you'll claim your credits and access your certificate. So on this presentation, all microphones are muted and all video cameras are off. Send all your questions and any technical issues you might have through the Q&A box. The chat box on this Zoom will be for faculty and staff. Again, all questions please send through Q&A, and I will function to review all the questions along with the other faculty when they can, and we'll get back to you and try and answer as many as we can in between discussions and as appropriate. So our agenda for tonight is first a welcome, which we're in the process of. Then I'm going to provide a case and just give a general discussion in regard to evaluation and management of phalanx fractures. Then we've got our sage, Dr. Mark Baratz, who's going to talk about how I do it, lessons learned, etc. Dr. Zelenski is going to talk about the complications and how you recognize them, how you get out of them, and real tricks of the trade. Then Gary Solomon's going to talk about how we turn these things back into functional hands after they've gone through all this treatment and all this injury. And then hopefully we'll have a little time for a case discussion with the panelists, and that's when we'll move to our Q&A. So our objectives obviously are fairly standard. They're to identify radiographic indications for various procedures, understand clinical criteria required for the indication for surgery or non-surgical care, define surgical anatomy and surgical steps in the execution of the procedure, whatever it may be, recognize pitfalls and complications and develop strategies to avoid them, methodology to deal with them. That's what Dr. Zelenski will be talking especially about. And review pertinent literature that's appropriate for our discussions. So as mentioned, this is a series. So this is a 3-case series, Fireside series for AO North America hand. And you can see we've already had one with wrist arthritis, today's phalanx fractures, Here you can see the series of the topics and the SAGEs involved all the way through December of this year. So lots of great topics. I'm sure lots of great discussions will be had. There are other webinars during 2024, as you see listed here on the left. In addition to some AO trauma hand North America courses, there's a hand and wrist fracture management seminar in March in Irvine, California, a fellows hand surgery course in May in San Diego, a hand and wrist fracture management course October in Jersey City, New Jersey, and then finally an advanced upper extremity trauma and flap course, which is cadaver-based, in November in Palm Beach Gardens, Florida. The webinars will be recorded and will be available 24 hours after our presentation, and they'll be available through YouTube AO North America. So without further ado, I'll go ahead and get started with just some general concepts related to phalangeal fractures and their management. This presentation that I'm going to give will just touch on some mechanisms of injury, anatomy, in particular deforming forces. It'll look a little bit at clinical and radiographic indications for induction and, if needed, surgical stabilization. It'll talk about general surgical technical pearls and some outcome determinants related to the fractures themselves and care of the fractures. So I don't have any conflicts related, though I must admit some of the drawings and the art are related to a book and a series that Dr. Wang and I have edited in 2021, volume 3 of Operative Techniques, Hand, Wrist, and Ethics. So I want to give them credit. So as we know, fingers are unprotected. They're subject to angular and bending forces and rotational and torsional type forces as well. They occur in a wide variety of situations, and as a result, there's a broad spectrum of fractures that we see. Sure, they follow kind of some categories, but in general, they can be very diverse. The fracture pattern depends, of course, on the position of the digit at the time of the injury and the direction and degree of force applied. Fracture displacement and deformity are influenced not only by those external applied forces, but also by the internal deforming forces really related to tendon and ligament paths and insertions. And we'll touch on that a bit as we go through this. Fingers are also subject to direct trauma and crush, of course. And those are the situations where skin, tendon, nerve, and arterial injuries occur and where the most challenging cases arise. And I have the feeling we'll see a few of those tonight as we talk further. So this particular patient, this is the case I'm going to take through, is a 45-year-old right-hand dominant female. It's a right long finger proximal phalanx. It's fractured, primarily extra-articular, somewhat comminuted, not that unusual. But you can also see there's an extra-articular base of the middle phalanx fracture present as well. In this patient, the coronal alignment is pretty reasonable. It's just displaced mildly to the ulnar side. If you look at the lateral view on the right, however, you can see the volar apex angulation that's present. 40 degrees is what I estimated. And you can see the translated middle phalanx base fracture. Not a lot of angulation, but volar displacement. So we know very well that deformity impacts function, right? And we know that rotational deformities probably have the biggest impact. That occurs through crossover deformity, as you see in the top row on the left. Proximal deformities can be problematic too. The more proximal they are, the more deformity and the poorer function we expect. Also, out of plane fractures, like you see the coronal angulation, the top row on the right, very important. But that's not to negate the impact of sagittal type angulation, which you saw in our case here. You know that with just 1 millimeter of proximal phalanx shortening, it's been said that there's about 12 degrees of compensatory PIP flexion given the slack placed in the extensor apparatus. So it's something to keep in mind. And the contributors to our deformity and the negative function is, of course, degree of deformity, but also the surrounding joint mobility and articular involvement, of course. So if we look just a little more at sagittal plane deformity, Fractures of the proximal phalanx will generally assume a position of volar apex angulation, as you saw in our case. The intrinsic muscle tendon units you can see on the top drawing here insert right into the base of the proximal phalanx and pull on that proximal fragment into a flexed position, whereas the central slip, along with the flexor tendons and the extensor tendon apparatus, tend to pull the distal fragment into extension, giving you volar apex angulation. Fractures of the middle phalanx deform in less predictable ways, to be honest, but they do assume a similar volar apex angulation in many situations due to the pull of the flexor digitorum superficialis and the pull of the distal extensor tendon on the distal phalanx and distal portion of the middle phalanx. However, you can see in our case, as you see the x-ray here, there wasn't any angulation, it was just translation, probably likely due to the fact that the sublimus insertion is a bit distal to the fracture or right at the fracture. So it does vary to some degree. When you look at distal phalanx fractures, of course, the terminal extensor tendon inserts over the proximal aspect of the distal phalanx, flexor digitorum profundus similarly, but still a little more distal. So you can develop deformities based on those insertions as well. So if we look at these fractures, obviously our goal with any treatment, and first non-operative treatment is appropriate. We need to reduce and we need to stabilize. And it's got to be stable enough to allow some limited mobilization and some functional bracing, as Gary will talk about as we get to that portion. So the first thing we want to try and do is relax those deforming forces we discussed. And then we want to think about those clinical and radiographic parameters and make certain we're in those parameters when we accept non-operative care. And of course, the clinical outweighs radiographic, but here you can see some just ballpark baselines to go by in terms of sagittal angulation, shortening, coronal angulation, or rotation. Even closed, though relatively simple fractures of the phalanges can cause scarring and surrounding soft tissue limitations. And it's important to realize how close the extensor mechanism is to the dorsal surface of especially the proximal phalanx, but also the middle phalanx, with only a very thin layer of periosteum and peritenon between the bone and the tendon. You can imagine how even in the simplest cases, without mobilization, that can cause significant scarring. As will be discussed in more detail later, early motion after injury or surgery can help minimize the contractures, the ligaments, and the adhesions between the bone and the gliding structures that Gary's really going to talk about. And this is, of course, an essential principle as we keep in mind the best treatment options for these types of injuries. You know, Chow and Peter Stern have said these things in the past, and I think they're very, very accurate. You know, if you have functionally stable fractures managed closed, especially if you can start some mobilization, they experience better outcomes. There's no question about it. Operative stabilization cannot always be equated to improved outcome. And in fact, it's not that hard to make somebody worse. So you can keep that in mind as you think about your treatment options. And when you think about those options, you really need to keep in mind the fracture personality. You know, and that's made up of the injury mechanism, the fracture characteristics, classifications, and numbers, as well, and most importantly, including the soft tissue environment and envelope, and what kind of contamination and other potential patient-specific factors you may have that will impact care. So our operative treatment goals, just generally, restore anatomy, obtain a stable reduction, and when you're doing so, minimize soft tissue disruption and irritation, and allow for early mobilization, controlled or as appropriate. Here you can see a young lady who underwent this, I guess you call it fixation, of a distal extra-articular proximal phalanx fracture. Clearly, that didn't work so well. The anatomy was not restored and was not stable. This physician then took the patient back and exchanged the K-wire for 2 screws. Really didn't improve the reduction terribly well and didn't obtain stability enough to move them. As a result, We have some bone in the volar fossa, which prevented flexion of the PIP joint, and this patient was taken back to surgery for removal of the implant and resection to obtain an ability to flex the middle phalanx down to the proximal phalanx. So surgical technique, exposure, minimizing soft tissue stripping, thinking of your implants and where you want to position your implants. So you can see the dorsal plate, and there are issues with dorsal plates. We saw, how close the extensor apparatus was, and how dorsal plate can impact that. And obviously, the implant here, one of the screws is limiting flexion and extension of this particular patient. Sometimes you can distract fractures when you're fixing them, not meaning to do so, and other times you can not have this stability, and that's seen here on the far right. Somebody who had to be immobilized ended up with really a non-united and stiff, deformed finger. So when we think about how these fractures are going to do, we think about some of the primary determinants. Proximal phalanx fractures tend to be worse actors than middle and distal phalanx fractures. Those that are articular are problematic. Those that are heavily comminuted requiring bone graft also tend to do less well. But most importantly is the soft tissue disruption. If you look at the good over poor outcomes here, from simple laceration down to combined injuries with flexor tendons, you can see how it really moves fairly quickly to a poor outcome. So being aware of those components and having appropriate expectations is important. So the keys to surgical success, obviously precise indications, realistic expectations, preoperative planning, intraoperative flexibility. That's all pretty standard orthopedic stuff. Technical precision and stability and reduction appropriate to allow controlled and early mobilization. So if we go back to our final plate, our initial plates, then this fracture, and I decided the best treatment for that would be a plate for that comminuted proximal phalanx fracture. This was a number of years ago, so plate's a little bit different now, but that was a fairly standard lateral plate, and extra-articular K-wires to fix the extra-articular fracture at the base of the middle phalanx. That seemed all well and good. Our alignment was reasonable, it was stable, so that would have allowed relatively early motion and early removal of the K-wires. On the lateral x-ray, remember we had that volar apex angulation. Well, I decided, maybe a plate would be good for that as well. And the plate was placed very nicely, but you can see I failed to reduce the fracture. And it was very easy to make that mistake. It was surprisingly easy for me, and I'll never forget it. It was years ago, and I still think about it. And fortunately, I was still in the operating room when I recognized it, put the plate in the right position, and she did just fine, did well. But, paraphrasing writer and philosopher George Santayana, those who do not learn from their mistakes are destined to repeat them. So, especially with these kinds of fractures, you'll learn a lot as you do them if you're not experiencing them already. And as you do so, you'll have failures, and that will be better. So with that, I'll turn it over to Dr. Baratz, and he'll give us some sage wisdom.
Thanks so much. That's a great lead in. My screen is in a position for you to see. And my index case for this would be that of the son, orthopedic surgeon playing soccer with his son, tried to block a shot and sustain this fracture. And he hit on a lot of really important principles. And a couple things that I hope to be able to add. Obviously important to look and see whether or not these are overexposed injuries on the side. And so appropriately the importance of soft tissue injury and outcome. Something that can help you is that it's often hard to look at a hand and know rotation without being able to bend the fingers. But if you look at the fingernails, and index and middle finger tend to turn in a little bit towards the sympathy, and the ring and small finger are slightly pronated. And that makes a very modest nail joint V shape. If you can only bring the fingers in a little bit, what they should do when you make a partial fist is they should have a nice cascade that I call the flex finger smile. So in those instances where this is going to be off, here you can see with the fingers extended, the small finger is, instead of turned in, turned out. So that's a broken V. And when you make a partial fist, you can see a perfect smile. We look on the radiographs for fracture pattern, whether or not we're dealing with normal body. And management, the knowledge of anatomy and past mistakes is going to be the passport to effective treatment. So this is the specimen where I made a longitudinal cut down the center of the phalanx so that you can see the extensive tendon so you can see the flexor tendon combo. And as you pointed out, the close proximity is what hurts us when that is malaligned or when there is hardware. We already talked about the role of the intrinsics, so I'm going to stick with that. So our lumbricals, our inflections, our central extension.
I'm sorry to interrupt you. We lost your sound from your computer. It's really hard to hear you. Could you, I don't know, you just...
Are you having a hard time?
Yeah.
Okay, let me try something.
Okay, thank you so much.
Sure. Is this any better?
Yes, maybe just slightly. That would be great if you could just speak a little bit clearer or louder into the computer.
Absolutely. Oh.
Thank you.
Okay, so the other important relevant anatomy, we know our MP joint trials are taught with MP flexion and their lax of extension. So that helps us in a couple ways. It helps us with reducing these fractures, but also helps us with avoiding problems with MP. So with non-operative treatment, we want to know whether or not the fracture can be reduced. And if it can be reduced, is it going to be stable enough to permit PIP motion? If we can get some PIP motion, we can get the extensor sliding above and get the flexor sliding below, and we can minimize adhesions in the fracture site and the tendons. And in general, my philosophy is that less is more, whether we do non-operative treatment or operative treatment. We want the least that's required to permit PIP motion and control rotation. So these are some of the options. This is a young couple who love racing motorcycles. Here you can see the husband has wrecked his bike, wrapped himself in a lot of Kevlar. So fortunately, the only thing that was injured was his knee. He had these fractures at the base of the ring and small finger proximal phalanges. In this instance, with the MP flex, which is at 60 degrees, when it is slim, we can permit some early PIP motion. And so you have to monitor this. You get an X-ray in the slim, make sure that you achieve the good reduction, and then within a week, make sure that you maintain a good reduction, because if you lose it, then you have to modify your management. But in this case, I get it, going, maintain fracture reduction, and failures of proto treatment here. So this is a person who had a fracture, intra-articular non-displaced, but you can see this obliquity through the base and shaft of fracture. And they were put into a cast which is opposite of what you need. MP is extended, IP joints flexed, and this is what you end up with. So this now, even though this fracture is healed, is a really hard problem. And the maxim that I want you to remember is bone and joint problems are generally fixable. We're really good at treating non-union. We're pretty good at treating things like malrotation, but we're not so good at treating soft tissue problems, and that's often the source of permanent impairment. So here's a woman who fell down flight of steps. She has this fracture, where you can see the proximal fragment. And then you can see the distal fragment.
We do have spatial modeling
And you can treat this with single pin fixation.
level careers and filet mignon on the top of any kind of
Mark
that's then owner of the exhibition.
series of
We have hot fish curry and filet mignon or noodle, any kind of noodle.
Closer you are to that central tendon, the more you're going.
I'm sorry. I think we might be getting audio from the restaurant. Is any? It's still really hard to hear you. I hate to interrupt you. I'm so sorry, but
No, let me see what I can do to help you.
I think it's the connection with the TVs and stuff, Mark.
yeah,
Okay.
is there a way to?
Let me see if that helps you. How's that?
No.
Don't-
Yeah,
don't
keep
have to
talking.
tell you. No. It's a weird thing, Brian.
Yeah, we're just
Okay.
getting about every other word. I'm not sure what happened from rehearsal till now, but no.
1 second.
How about now?
That's perfect. That's great. Thank you so much.
Yeah, we had a little tweak there.
Great.
Sorry about that. Now, let me get back to my screen. You're seeing the screen, okay?
We actually do not see the screen.
You don't see the screen.
No, but we hear you very well.
Ah,
So that's good.
all right, let's see here.
So now we're seeing your desktop.
Okay. Can you get him to stop talking? How is that?
Great. That's perfect. Thank you.
So if you put a pin down the center of the extensor tendon, you're going to constrain PIP motion. If you move to the side, it's going to facilitate PIP motion. Okay, so here is a technique with single pin fixation where the pin goes down the side of the proximal phalanx. And with it going down the side of the proximal phalanx, you can see that in a dorsal block splint with a strap over P1 and a strap over P2, there is no restriction to PIP motion. And at 8 weeks, you get someone who's got a little bit of a flexion contracture, but has really good PIP flexion. Alternatives are intramedullary screws. It's not something that I've done with regularity because of the problem that you see here. What you can see is that the screw, once you pick that plane, can translate the fracture in a way that you may not be happy with. Lag screw fixation we use for long oblique and for spiral fractures. Here is a fracture that you would think would be amenable to lag screw fixation. But when you look at the position of the finger, you look at the rotation, you look at how it looks like it's going to line up beautifully, you know that this is something that can be treated non-operatively. And in this case, we treated it non-operatively and ended up with a great result. So there are instances where lag screw fixation is very critical. And here we can see a great case of a long oblique fracture with malrotation and interfragmentary screws, good alignment, and a good result. This is a case, a very old case, Bill Hagberg's, where the only instance where I will use multiple plate fixation is when you have some of these very severe combined injuries. And for the metacarpals now, we're actually doing really nicely with intramedullary screws, We would not need plates for this. You still might need plate fixation for the phalanges. One of the last things that I wanted to show you before getting back to my index case was an instance where you have an intra-articular extension of the fracture, in particular on a small finger. This is a professional baseball player. This is not a great x-ray. It's hard to see, but you can see this impacted fragment on 2 views. And you can see here, through a small incision, I've disimpacted that fragment, aligned it, pinned it, and then offloaded it with an external fixator. And with a real nice result at 6 weeks. Another way to distract across the articular surface. This is a woman who came in and said, I have this fracture. I'm moving to Norway in 3 days. I thought that this was going to be a hard thing to manage without some sort of distraction across the joint. And here we used an internal distractor across the joint to hold the limited internal fixation that we achieved. I reached out to a friend in Norway and he removed the hardware for me. So back to my index case. This is this P1 fracture. And this was a case where I found that there was a tremendous amount of comminution mid-shaft. I chose to use interfragmentary screws for the articular portion, an interfragmentary screw for one of the long oblique portions, but then it was very comminuted through the shaft. And I debated doing a plate versus these pins. I chose to use the pins. At 4 weeks, this orthopedic colleague of mine called me and he said, hey, the pin is intruding on the joint. My finger doesn't hurt anymore. Can I just take these 2 pins out? And I made the mistake of telling him that he could without looking at him. And what you can see here is at 5 weeks, his fracture displaced. So the lesson here is that if you're taking care of a metaphyseal fracture, it's going to be healed in 4 weeks with closed treatment or even with percutaneous treatment. But when you do open treatment and you're dealing with diaphyseal fractures, it takes longer, particularly after you take down that fracture. And he would have been much better served if I had put a plate across that diaphyseal fragment. So I took him back to the operating room. I realigned his cortex. I repinned his fracture, but he had a compromised outcome, and it was because of a combination of suboptimal fixation and a bad decision at the 4-week mark. And that is it. I'm going to unshare.
Thank you very much, Mark. That was great. Dr. Zelenski, would you mind? There you go. Looks like you're up.
Thanks for having me, guys. I'll be talking about a complication of a finger fracture that I treated. Complications during these injuries are very common, and I think I've had about all of them. So I chose a case that had 2 complications in one, so we could hit a couple of birds with one stone. She's a 33-year-old right-hand dominant female. She came to me after she had her ring finger proximal phalanx fracture treated several years prior with a dorsal exposure and some of those nice lag screws that we've heard about. She subsequently, of course, had the lag screws removed, and these are her x-rays when she came to me. You can see she has a little piece of that volar bone, that sort of volar and ulnar. And her complaint is both limited motion as well as deviation of her finger. Her motion included a flexion contracture of about 40 degrees, with only 55 degrees then of passive flexion. Her active motion was equal to her passive motion. And you can see that she has ulnar deviation of her finger with flexion, which bothers her. And I'll just show that video again. She had a dorsal scar on her finger. So you're looking at the right ring finger, but her skin was well healed and her scar was supple and matured. This is her CT scan. You can see that volar ulnar piece of bone, and the fracture is well healed. So things I was considering going into this case, we needed both PIP flexion and extension. I thought she might have a bony block to flexion. I wasn't really sure if her tendons were pulling through. And she has a rotational correction as well as stiffness. So should we do this now or should we wait? So I was wondering if we could pick on our sage here, if Dr. Baratz would be willing to talk about any of those points and what he thinks about going into a case like this.
So Nikki, it's a great case. Thanks so much for sharing it. Is the audio okay now? You're hearing it well? Good. Thanks so much. Sorry about that commotion. So the issues are in this is that you certainly have a block to flexion, but what you have to do is you have to imagine those things that can't be seen on radiographs. So whenever there is a mechanical block to flexion, there's also going to be soft tissue structures that are going to restrict your ability to move. And so as soon as you remove that bony block, if it's been there for any period of time, as it has in this instance, you're going to have other issues. And the issues are on the top of the PIP. As a mechanical block to flexion, there's also going to be on the side of the PIP joint, the dorsal half of the collaterals are going to be tight. Proximal to the central slip in the capsule, you're probably going to have extensor tendon adhesions. And most of the time, particularly in the middle and ring finger, you're going to have intrinsic tightness. So those are all the soft tissue things that I think of when I see a bony block to movement. And then the question is how you best manage that. The truth is that you can't take care of one without the other. So you can't get rid of the soft, you can't correct the soft tissue issue without getting rid of that mechanical block. So it means both taking out volar bone and then addressing those soft tissues. And I think it's got to be done all at the same time.
Awesome. Thank you. It's advanced here. So, I think that just as Dr. Baratz kind of outlined, I think it's important to have a plan going in and have a plan of what to do after your plan. So we were going to start with a volar exposure, perform a tenolysis if needed, remove the bone fragment, and then go dorsal if needed. And like Dr. Baratz said, we were pretty sure that it would also be needed. So here's just a video from surgery. We do this through a Brunner. This is us just getting the soft tissue off of that volar piece of bone. And let's see if I can get this to play. So here we are. We've exposed the bone. We're working sort of just distal to the A2 pulley and moving the tendons aside. We did have to release a little bit of the pulley. And then we also do a volar capsulotomy and releasing the check brain ligaments to get some PIP extension. So after that, as Dr. Baratz said, we did gain a little bit of extension, but we really didn't get much flexion from that. So we were then planning on going dorsal as well. So I was wondering now if perhaps we could hear a little bit from our therapist, Gary Solomon, on what his considerations are for therapy after a finger surgery where you've made both a dorsal and volar incision, and how to manage swelling and kind of how he comes after that problem.
Sure. A couple of things which stand out when you see cases like this is that the finger, you're going to get, even if you get a great result in surgery on a Thursday, when they come back to the office on Tuesday, there's a good chance it's going to be a stiff, swollen finger if you don't do something between there. Immediate co-band wrapping is helpful. In a case like this, sometimes I'll order, and I'm not a huge CEPM person, but if ever there's a time for it, just to keep the finger flexing and extending, gently keep the soft tissues gliding over the weekend or for that acute phase is not a bad idea. Effectiveness for CPM is usually in the first week or so after surgery. So it's not a bad idea to keep the tissues gliding and then get them started on active motion right away.
That's awesome. I actually didn't know finger CPM was a thing. So that's really cool. And I think that's an awesome point. Never think that you're going to get more after these types of surgeries. You always lose a little bit, as much as you hope you're going to get a little bit. So we went dorsal. We performed a tenolysis. There was a ton of dorsal scar, both between the tendon and the skin and the tendon and the bone. That didn't get us what we thought it would. So we also performed dorsal capsulotomy and released the dorsal part of the collaterals, like Dr. Baratz said. So after the bone removal, the tenolysis, the volar capsule release, the dorsal tenolysis, and the dorsal capsule release, this was her motion. We had the advantage of doing this under, I call it sort of awake surgery. So she was asleep during most of it, but we did wake her up and ask her to then participate. We had her look at her finger, look at the motion that she had. She was relatively happy with the motion, but of course you can still see that that finger is malrotated. So I just wanted to bring this up a little bit, this concept of derotational osteotomy for malunited phalanx fracture through the metacarpal. You can get a great deal of correction by doing a metacarpal osteotomy. You're outside your zone of injury where we're making all of this new scar. So I want to pick on Dr. Baratz again. Have you done this? What are your opinions on that? And what would be your next step be here? Are you done, or are you going to do the osteotomy at this setting?
Yeah, so I personally would be done at this point, maybe not permanently, but would just let the finger come up for air. I think if you can pull off correction of rotation with whatever soft tissue procedures that you're doing, then it's a coup. For me, I think I would probably try to live to fight another day, and also consider if I knew for sure the exactly where I wanted to do that osteotomy, I might think about it. But I think letting her catch her breath after this and then come back would be my approach. But I'm excited to see how you handled it.
Thank you. So you do the metacarpal osteotomy for a correction of a phalanx malunion?
In general, what I do is I do it at the site of the malunion. But there are instances where you'll have a rotational deformity that, for instance, is very close to a joint. And you say, yeah, if I do this, if I try to recreate the fracture at this site, I'm not going to have a lot to hold on to. And that way, doing your correctional osteotomy remote from that is probably going to be more satisfying. But in general, I just try to, if I can get a nascent malunion, something that's only a couple months old, go through the same site, that's a beautiful thing.
Yeah, that's awesome. What a great tip. Thank you. We did not do that. We did the osteotomy during this surgery. So this is how I do it. So we had this big dorsal exposure. We were worried about coming back into this finger for now a third time. So we decided to do the osteotomy in this setting. I mark rotation. I initially start just by doing a parallel line, a line parallel just with the phalanx. So I can gauge rotation. I feel like using your bovie or using a marking pen, that always rubs off. So I just score the phalanx just really lightly. And that helps me determine kind of where I started. Then I perform the osteotomy. You can put a plate on before this, just on one side of where your osteotomy is planned. We didn't do that in this setting, but that's always a good strategy. So we performed our osteotomy. And then positioned our plate. We fixed it one side and checked our rotation and then fixed the plate. So again, we woke her up at this point and to assess rotation. I think having the patient participate is really helpful afterward, because then if you have a little bit of malrotation, they've been participatory in the whole process. So she looked at her finger. She was very pleased with where it was pointing. She was happy. So we decided to stop at this point. So here she is at 1 month. At 3 months, you can see this is her motion. She does still have a little bit of a flexion contracture at that the PIP joint, but generally she was very happy with the rotation of her finger. So I think that when you're treating stiffness, you have to isolate the problem, right? Like Dr. Baratz mentioned, is it extrinsic? Is it intrinsic? Is it tendon adhesion where your passive is better than your active, or is it a joint contracture? And what are you going to uncover when you start releasing these joints, or removing the bones if there's a bony block to motion? And you have to be prepared to do everything at that first or at that surgery if you need to. So extensor tenolysis, flexor tenolysis, and a capsulectomy. I will say that our pulleys were intact; they were all very robust, and we didn't need to do any pulley reconstruction. But this is something you just have to know how to do before you go into these surgeries, just in case you need to do a pulley reconstruction at that time as well. And my last parting words of wisdom are from Dr. Amadio. So every time you operate on a finger, it dies a little bit. So try to do it right the first time. And my response to him was always, every time I operate on a finger, I die a little bit. Thank you.
Thank you, Dr. Zelenski. That was fantastic. We did get a question that's probably up your alley, given the whole Grady involvement. What do you do in a situation where you have an open finger fracture? I think it probably would be proximal phalanx, primarily extra-articular, that also has a tendon laceration and it's contaminated. And for some reason, you don't feel like you can fix the flexor tendons right then. What's your strategy? How do you plan that? How do you handle it?
Yeah, I mean, I think that it kind of depends. I think that most personally, most finger fractures, I mean, if they're acute, they often can be debrided and the tendons addressed at that same time. But if not, if it's grossly contaminated, I think you just have to stage it. I don't have a better solution than that. Maybe Dr. Baratz, our sage, has words of wisdom on that. Obviously, like the priority is getting it clean, but Dr. Baratz.
I guess their question may have been getting at what kind of fixation do you use, given the fact that you've got to come back in a while and you probably need to be doing some motion during that time. I mean, how does that work?
I see. So if it's so grossly contaminated, I think that I can't repair the flexor tendons, I need to come back to do nerve repairs, then I'm not doing permanent fixation. So I will do like K-wires or something that can be removed.
Great. Thank you.
Nikki, how do you feel about spacers?
I'm pro spacer in the hand and fingers. I've had bad luck with like acute allograft. I know that there's some literature that's okay. I don't know if you have any other words of wisdom on that, but I love little antibiotic spacers. If there's bone gaps, I put vancomycin in it and I dye them blue so I can take them out later. Absolutely. I think that also can augment your stability if you're trying to get limited fixation just with K-wires. Then having a little block of cement is like almost like a rebar, and so that you can kind of start moving a little bit earlier. Obviously, you don't want to overstuff too much cement in there. You don't want it to get in the way of like tendons and stuff. But yeah, I'm pro spacer.
Well, that's great. Well, thank you very much. And let's transition on to Gary Solomon and hear about our therapy.
There we go. Got to unmute first. Okay. Now we're all set. Thank you very much. Going to talk a lot about some of the principles that we talked about as far as early motion and getting people going and some strategies to avoid stiffness. As far as therapy is concerned, the fracture management goals are really to protect the fracture healing, facilitate movement and function, and minimize and resolve any residual stiffness. And the key to positive outcomes is really to understand those factors unique to both the fracture, as we've seen a couple of times, and the individual. So the stability needs of the fracture and the activity needs of the individual. Our first encounter typically with the patient is when they come in for an orthosis, and we'll usually fabricate one to either immobilize or protect the fracture, maintain reduction, and facilitate uncomplicated fracture healing. We typically use either thermoplastic or functional casts, which are polyester casting tape material. They have a little bit of flexibility, but for somebody who's very active, I think they can give a little bit more protection. And you can also self-adjust. You can accommodate for edema a little bit because there is that little bit of flexibility in there, even though it's a pretty rigid construct, especially where you need it. As we've talked about, if we'd had this talk several years ago and not that long ago, it would have been that the fracture management of a fracture that didn't have stable fixation, screws or plates, would be to immobilize it. And we've evolved a lot from that over the past few years. So the early phase, we want to control the edema. That's critical early on. Movement of uninvolved joints. Now we're always looking for opportunities of movement for the involved joints, especially those PIP joints, as well as ADL adaptation. Dr. Don Lalonde and Amanda Higgins have published how they do it, and they call it pain-guided motion. So basically, you're allowing that early tendon glide, limited motion of the digits, not a lot, a limited arc as soon as the patient's off analgesics and as soon as about 3 days from injury or surgery. The motion shouldn't increase pain, and pain is usually the guide. That's what you have to use. It's just gentle, pain-free motion in a short arc to keep those soft tissue structures gliding. So we've had this evolution from strict immobilization of a fracture to now we're looking at how much can we move it. And it's a question, think of it as a dose of how much stress can we put on it and for how long. So we can do a little bit of motion a few times a day or throughout the day. With rigid fixation, such as plates or screws, it changes it a little bit. Then we're trying to do early facilitation of a full arc of motion. The limitations from plate and screws that's been discussed is really more from the soft tissue disruption. So the tendon and scar adhesions are actually more problematic than the joint stiffness. In the early phase, we want to really facilitate functional grasp patterns. So in pain-guided ranges and a lot of bilateral type activities to get people moving again. So we like to do range of motion with them and then sort of add on more functional components. As they progress over the next few weeks, the focus changes towards the end ranges. So we want to start to spend more time, and that's how you gain range. You spend more time at the ends of the range. So rather than just going back and forth, you start to do more activities that are for sustained grasp And then as we move on to the late phases, a lot of people think of this as the strengthening phase. I don't think losing strength is a huge problem with digital fractures. It's more reestablishing normal movement patterns. And I think great ways to do that are start to use speed and dexterity. So a lot of activity simulation, functional use, and have them stop thinking about moving their hand and just find ways that they just do it. And that tends to get them over that last hump to get back to daily activities. As far as any extension lags or end range of motion difficulties, there was a good article, it's kind of old now, it's from 2003, but on preloading and tendon acceleration. And this is something, it's a higher dose because it is pretty forceful, but you're talking about preloading the digit and working on that active pull through. This is someone just kind of working on that PIP extension. Just a quick mention of distal phalanx fractures. This is my daughter's finger from a field hockey accident. The ball hit her hand while it was on the stick. Usually movement initiation, it's dependent on the fracture location, but that's usually not the problem. Hypersensitivity and use avoidance of the digit is typically a lot more problematic than range of motion. So even though there's those small tuft fractures, or those very distal type fractures, sometimes they do need a little intervention just to get them using the hand again and to deal with the hypersensitivity issues, because it's very easy to avoid the digit, and then it becomes stiff. One of the things which are the key to success for therapy is trying to plug in the right tools at the right time to get people moving again. And we use different orthoses to facilitate that. In the early phase, what we're looking are for orthoses to redirect active motion towards the PIP joint. That's typically what the problem is your stiff PIP joint. So for those, we have blocking and relative motion. Here's an example with blocking. And basically, if a patient cannot hold their MPs in extension when you ask them to flex the IPs, I like to intervene and give them a nice blocking orthosis. And they're easy to take on and off, and I'll have them use them periodically throughout the day and just work on moving. And then relative motion orthoses. You see this pattern a lot, and it was also in one of the cases when people can't flex their IP joints, you see that hyperextension of the MP, hyperflexion, of the MP joint. So you need to redirect those forces so the IPs can then, the momentum of the flexor tendon can then curl or flex the PIP and DIP joints. And you also see it for extension. You can see in the bottom picture that there's that MP hyperextension, and you need to block that in order to get the full PIP extension. So here's relative motion in action. So that one is to reestablish flexion. It blocks that MP and range flexion and redirects the force. And then this is for PIP extension. If people are still having trouble with motion at about 5 or 6 weeks and the fracture seems to be stable and healing, that's a good time to introduce light force over a long time. And we can do static progressive or dynamic type orthoses for that. The key is light force and emphasizing time. So many people want to crank it. That's not the goal. It's to just provide that tension, like braces on your teeth. You just go light tension over a long period of time, and then the tissue expands and you can restore that passive motion. And in the late phase for those flexion contractures, I like serial casting, but you have to make sure that the flexion is good first. And this is a high dose treatment. This is, remember, it's low force, but it's a very long time. We either go once or twice a week with this, but it's extremely effective in resolving those PIP flexion contractures. So just kind of to run through the decision tree, if I ask the patient to make a hook fist or a claw, if they can't maintain that MP extension, I like to do a blocking orthosis to reestablish flexion. If they try a composite fist and that MP is hyperflexing, then I'll introduce a relative motion. If the joint stiffness is not resolving with just active motion at about 5 weeks out, I like to introduce light tension. And then for extension, a night orthosis to hold the PIP joint in extension is beneficial early on, and then progress to relative motion. Then LMB is just a small dynamic orthosis from off the shelf. And then if there's still residual stiffness, serial cast can be very effective. Just a quick case in Chicago, a lot of people play what's called 16-inch softball. I don't know if they play it anywhere else, but it's played without a glove. So we tend to get a lot of fingers that look like this. And this one, motion was initiated at 5 days post-op in a gentle pain-free arc, gently supporting the proximal phalanx. And I gave them the support of the blocking orthosis because they did better with that. You can see at 3 weeks, they had good flexion, but you had that extension deficit. So just reintroduce the relative motion concept to restore the PIP extension, and at 5 weeks, they had full motion. So it's never a one-size-fits-all situation. You want to always seek opportunities for safe motion if the joint as stability permits, because it's so important to get those soft tissues gliding early on, or everything will just get stuck. And then use orthoses early to reestablish the appropriate movement patterns. So thank you very much. Stop sharing.
That was great. Thank you, Gary.
Thank you.
So Dr. Baratz showed a young female, I think, that had a oblique proximal phalanx fracture. It was treated, it was somewhat displaced, and it was treated non-operatively. She had an excellent functional result. From both of you, how do you manage that? So Mark, I guess first for you, she comes into your office and, do you immobilize her? Do you splint her? Do you, tell me the process.
Yeah. So my preference is to use dorsal block splints. Excuse me. a dorsal block splint with a strap that goes over the proximal phalanx and a strap that goes over the middle phalanx. And so the dorsal block is to get the MP down. It is to maintain alignment of the proximal phalanx. And then the straps, this one stays on, this one comes off to allow PIP motion. And I've had good luck with that. I love the cast that Gary made. I think that's a beautiful thing when you can get someone to do that. But the principles are the same. In general, for P1 fractures, we want to get the MPs down and we want to get the PIP joint moving as soon as is safe and possible.
No, definitely agree with that. And sometimes I'll even, we'll have a second one, and it depends again how active they are. Sometimes we'll go all the way for the digits, like an ulnar gutter on both sides, just to protect them during activities, depending on what they're doing during the day. But always, I like them to move with that MP inflection to start.
And just one other quick question for you, Mark, and I guess also for Gary. You kind of started your talk out by discussing how important PIP motion was, and the fixation or the treatment was really geared toward making sure you could initiate PIP motion early. Tell me about that. I mean, when you're talking about initiating PIP motion early, are you talking about full flexion? You're talking about a jog motion? What to you is the critical amount of PIP motion to get moving really early that impacts your method of fixation or treatment?
Yeah, so from a tendon standpoint, you actually don't need that much PIP motion. So if you get 20 degrees of PIP motion, that's going to create enough glide across the proximal phalanx that you don't get the tack welding of the fracture to the tendon. But for the PIP joint itself, the PIP joint is the heart and soul of the finger. And so we tolerate DIP joint stiffness pretty well. But if we're lacking PIP motion, that's a big deal. So I try to get them moving. I try to come up with some strategy for taking care of a finger fracture that lets me move the PIP joint. If it's a bad middle phalanx fracture, I'm willing to put a longitudinal pin down the middle phalanx to support that fracture, giving up some DIP motion in exchange for full PIP motion. And so it's the premise of treating phalanx fractures. Treat the PIP joint with respect, because that's where your win comes from.
I think that's great sage advice. Thank you. Thank you for talking about that. And you had something else you wanted to mention regarding release of soft tissues?
I'm happy to show this. We'll see if we can get through some of this relatively quickly. So we talked about, is that showing up? Are you able to see my screen?
Yeah, looks great.
Good. So we talked about the culprits in the finger with regard to loss of flexion, being the extensor tendon adhesions, dorsal capsule contractures, dorsal half of the collateral ligaments, and then plus or minus flexor tendon adhesions. Something that I've come to appreciate more is the loss of normal redundancy and pliancy of the skin that surrounds the PIP joint. So in order to get the finger soft enough, the skin soft enough to do a contracture release, it usually means that Gary's going to take care of that person for 6 months. So it's rare for me to do joint release surgery in less than 6 months, because we want a soft, pliable, redundant envelope. And I'll just show you an example here. This is a person where I had done, they were referred in after a finger fracture. This was their motion, was very poor. Their skin seemed pretty soft around the PIP joint, not as much as the adjacent finger, but it seemed pretty soft. And here you can see me doing my extensor tenolysis through a dorsal approach. And you can see here doing release of dorsal capsule. freeing that up. And then still having a problem. And so now I've got to release the dorsal half of the collateral ligaments. And so once we do that, we've done extensor tenolysis, we've released our collateral ligaments. Now I've got passive PIP flexion. Okay.
So you're ready, on, and make a fist for me, pull it in.
But I'm asking her to make a fist, and she can't. So in spite of having passive flexion, there's no active flexion. And so in this particular instance, I flipped it over. I did a flexor tenolysis.
Okay, straighten out.
And in the operating room, I'm thrilled. I'm doing this under local. So she's making a full fist. I think I've done a wonderful thing for her. We're all giving each other high fives. But then when you go to close that dorsal skin, you can see what happens. And so what I've basically done is I've gone to this too soon. I don't have enough soft tissue for her to be able to recreate what I got in the operating room without gapping her skin. She gaps her skin. There isn't much between her skin and her joint at this point. And so it brought me to this minimally invasive technique. And we did this in the lab first. And the point was to come up with a new way to release the targeted structures. And so the idea was that many of these patients have intrinsic tightness. So we had to do an intrinsic release. And in addition, we had to go above and below the extensor tendon with an extensor tenolysis. We had to release the dorsal capsule, and we had to release the dorsal half of the collateral ligaments, and we might have to do it at both spots. So we did this in some cadaver specimens, and I'm just going to bop through this very quickly. But basically, what we were able to do is through a small incision, get above and below the extensor tendon. When we went below the extensor tendon, we were able to release some of the dorsal capsule and then use a 18 gauge needle as a percutaneous scalpel to release the dorsal half of the collateral ligament and then manipulate. Okay. And so our results were that we were able to accomplish this. We didn't hurt anything. We nicked a lateral band, which was not significant. So we proved that we could do this. So this is a case that Steve Moran sent me from Rochester. This fellow had, on the 4th of July, had a firework go off in his hand. You can see that he lost his thumb. He lost the end of his index finger, the end of his middle finger, had fractures of both index and middle finger proximal phalanges and his metacarpal. And so this is him at about 8 or 9 days when I first met him. And then this is him 6 months later after he's worked with the therapists and tried to get that skin in as good shape as possible. This is his active flexion. This is his passive flexion. And I'd made a commitment to, we talked about rebuilding his thumb with a toe, but I told him we wanted him to have a good hand before trying to give him a good thumb. And so for this case, what I'm going to show you, all the local anesthesia is placed on the dorsal aspect of the hand and the finger. And what we're doing here is we are looking at the intrinsic through a little mid-axial incision. And you can see that it's tight. And then I'm just going to do an intrinsic release. You'll be surprised how many trauma patients of yours will have intrinsic tightness. This is a common finding that we often don't pay attention to. Okay, and now I'm using a freer elevator. I've gone above the tendon and I'm going to go below it. And I'm going to free up all the scar tissue from that blast injury. I'm also going to loosen up some of the skin around the PIP joint. Now I'm taking the freer over the proximal phalanx. I'm taking it over the metacarpal head. I'm taking it over the metacarpal plate and shaft. And you can see all those dense adhesions all the way down to the wrist joint itself. So you have to, again, have a picture in your mind of where all that scar is going to be that's going to limit finger mobility, because it's super frustrating to release a joint and then not be successful because there's scar proximal to your site of release. Okay. So now the thing that I have left to do is I've got to release his PIP joints. And so to do that, I'm going to use this 18 gauge needle as a percutaneous scalpel. And I get to the midline and I just lift from midline up. And I'm underneath the lateral band at this point. You can actually feel yourself pop into the joint, and you'll get a little bit of the dorsal capsule at the same time. Now I have passive flexion of the PIP joint. You have to do this on both the radial and ulnar side, obviously. And now I do the same thing on the middle finger. Do the same intrinsic release, extensor tenolysis, releaser of dorsal half of collateral ligaments.
Well, right now, and then, you happy? Yeah, what a difference. Okay.
So this has made a big difference for me, because these people I can send to therapy right after the surgery. A lot of times I'll give them a day or two, but I'll also put them on steroids, and I don't worry about the steroids having a problems with the wound, because the wounds are so small and they're not under tension. So I think I'll just I'll leave it at that and see if you have any questions or comments.
I don't see any specific questions related to that in the chat, but I got to tell you, that was a nice little addition to our webinar. I really appreciate that. Thank you so much. I'm sure lots of people do have questions, but it's hard to get them typed in and so forth. So thank you very much. I did receive one question, though, that I'd like to give to you or to Nikki. It really just simply relates to treating phalanx fractures in general with K-wires. And when you remove those K-wires, whether you immobilize them while the K-wires are in, and then when do you start therapy if you have K-wires in your finger? Maybe it's a proximal phalanx fracture, extra-articular, that you have two K-wires in, or something such as that. And when do you pull those K-wires?
So for me personally, what I'm doing now is all of my wires are beneath the skin, and so I'll cut them, leaving just a little bit of nubbin. When the hand swells after the surgery, those pins are not an issue. But typically at 4 weeks, I will, in the clinic, numb their skin, and just with a needle holder, push the skin on either side of the needle and pull it out. The pins out that I showed you in that case of my orthopedic surgery colleague, those can do okay for 3 to 4 weeks, but they're way more trouble than they're worth. And I've given up having hardware outside of the skin when I can.
That's exactly how I handle it too.
Yeah.
Well, I think our time is up, and I'd really like to thank all our faculty. You are a fantastic sage, Dr. Baratz, so thank you so much. Nikki, your presentation was excellent, as was yours, Gary, and I really appreciate all the interaction that occurred, and I think our audience probably very much enjoyed it. So thank you all very much for your efforts and your time. One thing to remember is for the audience is this will be available on YouTube after 24 hours, and you can expect an email, I think, after the series is over, but I'm not really sure how that happens in regard to your questionnaire and your CME certificate. So with that, unless Mackenzie, I'm forgetting anything, I think that should be about.
That's it. Thank you.
Thank you all. Have a great night.
Good night.
you.